Unit 6, Drugs Acting on the Cardiovascular System. This is a review of the cardiovascular anatomy and physiology. Please look at these images. You don't really have to memorize it. Just be familiar with the structures of the heart because it kind of gives you an idea of how some of these medications work. The major ones that you have to know would be your superior vena cava, inferior vena cava, your left coronary artery, right coronary artery, aorta, your pulmonary arteries, your atrium, ventricles, and so on. For the purposes of this course, you have to remember the cardiac cycle. So where does the blood flow goes, right? Where does it start? Where does it end? So in a cardiac cycle, the heart goes back, right, from everywhere in the body. It returns to the heart through the superior and inferior vena cava. It goes to the right atrium, then the tricuspid valve, then the right ventricle, then it goes to the pulmonary valve, pulmonary artery, then pulmonary veins, then it goes to the left atrium, mitral or bicuspid valve, left ventricle, and then it goes to the aorta, and then it goes to the different parts of the body. Then the cycle begins again. This is the renin-angiotensin-aldosterone system. So this is basically our body's way of regulating blood pressure. So when our body senses a drop in blood pressure or a drop in fluid volume within our body, our kidneys will release renin, and then the liver will release angiotensinogen. So what happens is the renin will convert angiotensinogen to angiotensin 1, which then will be converted by ACE into angiotensin 2. So ACE is angiotensin converting enzyme, which is released from the lungs. Now, angiotensin 2 can directly cause an increase in blood pressure because it acts on the vessels directly, causing vasoconstriction. On the other hand, angiotensin 2 also acts in the adrenal gland, stimulating it to release aldosterone. So aldosterone acts on the kidneys to stimulate absorption of salt, sodium chloride, and water, right? So thus resulting in a higher blood pressure or a higher blood volume. So it is very important to remember this moving forward because many of your blood pressure medications can actually work by interfering with a step here in the RAS system. So please remember this, memorize it, and understand how it works. And this is just a list of what happens. So when the blood pressure is low, renin is released from the kidneys, and then it converts angiotensinogen from the liver to angiotensin 1, and then the lungs produce angiotensin converting enzyme or ACE, and then ACE converts angiotensin 1 to angiotensin 2, and then angiotensin 2 causes peripheral vasoconstriction and also the release of aldosterone. Aldosterone causes sodium reabsorption, which then causes an increase in blood volume due to water retention, which ends up resulting in a higher blood pressure. In addition to understanding how the renin-angiotensin-aldosterone system works, we also need to understand how the different receptors work within our body. So depending on what receptor we are talking about, it actually has an effect on certain parts of our body or certain smooth muscles, which can then affect our blood pressure. So first, let's talk about the alpha receptor. So we have alpha 1 and alpha 2. So when we're talking about alpha 2, it actually affects smooth muscle contraction. So when you think about it, where do we have smooth muscles? So they're basically everywhere in our body, but mainly you will see them in your blood vessels, pupils, your pylorus in your stomach, urinary sphincter, and prostate. So an easy way to remember alpha 1 is with the acronym 1, ONE, so 1 blood vessels, N is neck of bladder, prostate or stomach, and then E, eye. So those are the organs that are being affected by the alpha receptor. So when we're talking about certain drugs, if it's an alpha 1 blocker, then it kind of gives you an idea, okay, what is it affecting, right? What can happen to the patient's body if we are blocking something, we are blocking the alpha 1 receptors. Anyhow, you will understand this a little bit better once we start talking about the different blood pressure medications. Now, another receptor, like I mentioned earlier, is the alpha 2. So alpha 2 is a little bit different because it actually works within the nerves. So it works in the presynaptic nerve terminals. So alpha 2, TWO, terminal weaning off. And this actually has an opposite effect compared to the alpha 1. And again, we're going to go over it again later on once we start talking about medications that will affect these receptors. Next are your beta 1 receptors and beta 2 receptors. So an easy way to remember, and I teach most of my students or all of my students, would be beta 1, you have one heart, and then beta 2, you have two lungs. So just knowing that, it will kind of give you an idea of what it affects. So there are some medications that will affect beta 1, beta 2, or a combination of both. Anyhow, so beta 1 mainly affects the heart and the kidneys, and then beta 2 can affect so many other organs, basically because of smooth muscle relaxation. So it can affect the lungs, blood vessels, GI tract, bladder, uterus, liver, and then it does affect glucose as well. So you can see that certain medications can cause an increase in blood glucose levels. So again, beta 1 heart, you have one heart. Beta 2, you have two lungs. And we are going to go over its effect again once we start talking about beta blockers. Another receptor that it's good to know and understand are your dopamine receptors. So a third type of adrenergic receptor. So in addition to your alpha adrenergic and the beta adrenergic receptors, where we have dopamine receptors. So this is basically located in various tissues and organs and activated by binding of the neurotransmitter dopamine, which can be either endogenous or synthetic drug. So it just depends on, if it's our body will produce that as well, or if we're giving something with dopamine. Anyway, so it affects movement, cognition, pleasure, and motivation. So not only it affects the blood pressure, dopamine actually can increase or decrease the blood pressure depending on the amount of dopamine and the concentration. But in addition to that, it actually affects coordination, movement, and a patient's mental function. So that's something that you may want to remember when we're talking about the dopamine receptors and the drugs that affect dopamine levels and the dopamine receptors. Let's turn your page to page 12 of your outline, and we're going to be talking about some of the pathophysiology, signs and symptoms of certain disease process that we're going to be going over. First is a coronary artery disease, or CAD. CAD, any one of the abnormal conditions that can affect the arteries of the heart and produce various pathologic effects, especially a reduced supply of oxygen and nutrients to the myocardium. So again, in simple words, this is basically a group of diseases that can affect the perfusion or blood flow in the heart. There are some risk factors. You have non-modifiable and modifiable risk factors. Non-modifiable, pretty straightforward, are some things that we just can't do anything about, and unfortunately, there's still risk to develop that disease. So non-modifiable includes age. So CAD is more common in people older than 50 years old, women after menopause, Black Americans. Men are more likely to develop CAD than women. And then there are certain things such as genetics. So if hyperlipidemia exists in the family, that may be something that we can't control. Some of the modifiable risk factors or things that we can change or we can control are the following: diabetes, hypertension, elevated cholesterol, elevated LDL, poor diet, excessive alcohol intake, obesity, sedentary lifestyle, emotional stress, and smoking. And for some of you may be wondering, well, why diabetes? If a patient already has diabetes, they can't do anything about it. Actually, you're wrong. So typically, unless it's, your type 1 diabetes, generally speaking, most people with diabetes have diabetes type 2, which is basically modifiable. People can actually change their diet, be more compliant with their medications, and they can actually get those diseases under control. Same thing with your blood pressure, right? So typically, if patients are compliant, then their likelihood of developing CAD will be lower. Now, if they're not compliant, blood pressure is out of control, diabetes is out of control, cholesterol is out of control, then their risk goes higher. Clinical presentation of CAD. So patients experiencing CAD may come with various symptoms. Some actually are asymptomatic, but if they come with symptoms, they may complain of crushing, heavy pressure or tightness in their chest. Some patients may say that they're nauseated. Typically, patients will complain of sternal pain, so in the sternum, mid-chest area. Some people will complain of jaw pain, left arm pain, intrascapular pain, or in the back between the shoulder blades. And for some patient, there may be a pattern. For some, they may say that it's related to certain activities or precipitating factors. There may be some varying duration, and depending on what type of CAD it is, there may be instances that it can be relieved by certain medications or really just stopping whatever is triggering those symptoms. Now, there are some drugs that we use for CAD. So morphine, oxygen, nitroglycerin, and aspirin are all used for CAD. And so when you think about it, right, CAD is a problem of within the vessel, right? So typically it's because of narrowing or spasming of the vessel and not allowing blood flow, right, up to the coronary artery. So what happens? Well, morphine actually helps with the blood flow by causing some relaxation of the vessels. It also helps with pain, and it also decreases the myocardial oxygen demand, thus kind of helping and making sure that the heart doesn't have to work as hard. And then oxygen is pretty much straightforward. Increasing the oxygen concentration helps as well, and make sure that the tissue is not gonna be dying or becoming ischemic. Now, nitroglycerin is a vasodilator, and so when you think about vasodilator, it dilates the vessel, so it relaxes the vessel, so it allows for more blood flow. And then aspirin, it actually prevents clots from forming, and so again, if it's doing that right, so if the blood is not as sticky, then it prevents clogging or clotting within the coronary arteries. Now we're going to be talking about angina. Angina basically means chest pain. And for patients, there may be so many other reasons for chest pains. And depending on the presentation, it may be categorized as follows. So it can be a stable angina, presmental or variant angina, or unstable angina. So in stable angina, so stable, from the name itself, when something is stable, it means it's predictable, it's not as bad, right? So stable angina pectoris is basically a type of chest pain that's temporary and reversible and usually has a distinct pattern. So it's pretty predictable. Now, it is usually caused by coronary ischemia, usually by a certain trigger. So depending on the patient, their situation, they may have different triggers. So for some patients, exercising can start causing some chest pain. And so typically with stable angina, once they stop that activity, then their symptoms get better. And other examples would be from tobacco, sex, stimulants such as cocaine, and anemia. Now, pain generally subsides once the precipitating factor is eliminated. And usually it's treated medically depending on what's going on. So sometimes the patient may need some medication to kind of help alleviate the symptoms faster. But then typically, just anticipating the triggers, controlling the triggers, or maybe avoiding certain activities or certain lifestyles, that can actually help prevent or treat a stable angina. Now, Prince metal or variant angina, this is actually more of vasospasms of the coronary arteries, which can then lead to coronary ischemia. So this is often seen with patients who already have some sort of disease processes related to vasospasms. So migraines and Raynaud's, so these tend to co-occur with metal or variant angina. Now, the first line treatment, so knowing that it is vasospasm, right, then you want to treat the spasming. And one of the really good treatments for vasospasms are your calcium channel blockers or CCB. So CCBs are basically smooth muscle relaxers that causes the vessels to stop spasming, and then rather than spasming, it causes relaxation of the vessels, allowing for better blood flow. And similarly, nitrates are vasodilators as well. They're quite stronger actually, and so that also has a very similar effect to calcium channel blockers. Unstable angina, on the other hand, this is due to coronary artery atherosclerosis or plaque rupture. So this typically, from the name itself, it's unstable. This is not good, right? So this typically causes a new, sudden, acute pain, intense pain, and it doesn't matter what the patient is doing, whether they're resting, and that pain is unpredictable, and typically it's really hard to figure out what can make it better. If we don't get coronary artery disease under control, there can be some consequences. So let's say CAD is not under control. It can lead to coronary ischemia, and then prolonged ischemia can lead to cell damage or death, which is basically myocardial infarction. So once a cell has infarcted, a tissue has infarcted, it's really irreversible. It's done, right? Anyway, so talking about myocardial infarction. So what is myocardial infarction? This is really a result of sustained coronary ischemia leading to irreversible cell death. What are the signs and symptoms of MI? So MI, for those of you who are not familiar with the terminology, is basically a heart attack, right? So signs and symptoms of a heart attack or MI. Patients may complain of intractable chest pain. When we say intractable, it means that it doesn't get better. So it's there. It doesn't matter what we do. It's constant. It's there. And it's unrelieved by rest, oxygen, morphine, and so on. So a good indication, well, it's not good, but an indication of myocardial infarction is if you're giving the patient your MONA, right? Morphine, oxygen, nitrate, and aspirin, and the patient's still complaining about the same symptoms, right? There is a high likelihood that that patient is experiencing a heart attack or myocardial infarction. So the description and location may vary depending on the patient. For some patient, there may be some changes in the vital signs, maybe an increase in heart rate initially, but actually it can also lead to a decrease in heart rate. Heart tones may start changing. They may start having extra heart sounds. And then if you're looking at their EKG, their cardiac rhythm may have some changes. And you guys will go over it down the road, probably in your second or third semester. But it's just good to know that in general, it can change how your heart is going to be beating. And then for some patients, they may experience pulmonary crackles, sounds of fluid within the lungs. It's typically a result of the heart failing. And then dyspnea or difficulty breathing, fatigue, diaphoresis, nausea, and vomiting. Now, when a patient is experiencing the symptoms, typically we would order some cardiac enzymes, which include troponins and your CKMB. Complications, it just depends on the patient. This is not all of it, but you would often see dysrhythmias from patients having a myocardial infarction, pericarditis, inflammation of the pericardium. Again, like I mentioned earlier, it can lead to
heart failure, and cardiogenic shock, and ultimately, right, it can lead to death. So general treatment for MI, again, we administer our MONA, we make sure that we're providing adequate oxygen, and then because there's such a huge risk for the patient to develop some dysrhythmias, it is very important to make sure that our electrolytes are within certain levels, especially your potassium and magnesium, because when your potassium levels are really low or really high, and similarly with your magnesium, it can actually lead to dysrhythmia. And if you already have a patient who is at high risk for developing a dysrhythmia, right, and they have a heart attack, and then now their electrolytes are off, most likely that's what's really going to kill off your patient, is because of that dysrhythmia. So make sure you're monitoring. So any patient that's coming in to your hospital, your facility with an MI, they need to be monitored, right? They need to be on continuous EKG monitoring, so you can pay close attention to that. But also we need to check their electrolyte levels, and if any of them are abnormal, we need to make sure that we're correcting them with the appropriate treatments. Now, if they have a dysrhythmia, we have to also treat it. And with MI, time is very important. We make sure that we act accordingly. Things should be done basically almost immediately, because the longer we wait, the more cardiac tissue is gonna die, and it's harder for the patient to recuperate. And again, then if we don't act fast, then it can lead to some of these complications that we talked about. It is very important to offer support to the family, to educate the patient and the family of whatever we're doing, the purpose, and when appropriate, depending on what's going on, we need to start talking about how to care for themselves when they're gonna be discharged home, because ultimately we don't want them to come back for the same problems, or even worse, for some complications, because they did not get their disease under control at home. And again, it's very important for them to follow up with their provider, and it's not enough to just, I'm in the hospital, I feel better, and that's it. It is very important to follow up and make sure that they're compliant with their treatment, and then also so that we can address anything else that they may need if they follow up with their provider.